Good afternoon, everyone. Welcome to week 2 of OB tutoring. Go ahead and for everyone, let's go ahead and do our QR code. These are really important so we can get a good attendance, and I'll go ahead and show this at the end as well. So if you're coming in late for the SI, it's okay. Alrighty, if you guys, if anyone missed that, we can always come back to it. And then here again is my contact information. If anyone needs to reach out to me, there's my personal phone number, there's my email, and then of course, kind of how you can reach out to me through email. Moving on. All right, so the first thing here, if you don't have your slides downloaded or with you for pen and paper, I really recommend that. We're kind of going off, I kind of really made it fill in the blank for you guys to kind of help out with that. So just terms to know, just kind of reading off right here. We have gestation. That's going to be the number of weeks since the first day of their last menstrual period. Abortion, that can be any birth has occurred prior to 20 weeks gestation, or also called a miscarriage. We do have our miscarriages that are abortion that occurs naturally, but these can also be called spontaneous abortions. We have early term. Early term is, of course, the origami term. They're just going to be a little earlier, starting at 37 weeks and going through the end of the 38th week. We have full term, which is 39 weeks and through 40 weeks and 6 days, because after 40 weeks and 6 days, it's going to be then late term. Then after the end of the 42nd week, or I'm sorry, the beginning of the 42nd week, it'll be called post-term. And then anywhere between 20 and 37 weeks is going to be preterm. If anyone needs to like write this on a diagram or just, I don't know, just always reference this, it'll help a lot. And of course, you'll notice a trend with a lot of Harold's PowerPoints moving forward for the next good month or so. We're going to have these words here: antepartum, which is prenatal, the time between conception and the onset of labor, usually used to describe the period during which a woman is pregnant. We have intrapartum, which is the time from onset of labor until the birth of the infant and the placenta. And then after that, they're going to go to postpartum, which is going to be the time from birth until the woman's body returns to an essential pre-pregnant condition. More terms here: prenatal, occurring before birth; perinatal, before delivery, from the 28th week of gestation through the first 7 days after delivery. And then if anyone's wondering why 28 weeks, because at that time we do have, I believe it is surfactant of the lungs is produced finally, and our babies can breathe. After that, postnatal, occurring after birth. And then this right here, gravida, all this stuff right here, really pay attention to this. This is pretty important. So gravida is going to be any pregnancy, including present. So, on your homeworks or for like maybe a potential exam question or something like that for any time of the year, if you have, if a patient's coming into the clinic for prenatal care, obviously her gravida number would be including that potential baby as well. It's any pregnancy rather. And then primigravida, the first pregnancy; multigravida, more than one pregnancy. And then we have things like para, nullipara, and primipara. I'll let you guys go ahead and read that. And keep in mind, this stuff can be, you can really like apply this to any exam question to kind of just get the motions moving. I remember when I was at clinical, we actually had to, looking at their chart, explain all of this to the nurse that we were with, she wanted us, I mean, you can see these numbers, it'll say GP and things like that, but to be able to explain that to someone is really helpful. How are we doing on our, if anyone's typing in or filling in? Living children. So if there's a question about that, usually it'll be pretty obvious on the questions that you're looking at. So yeah, I would say always assume that they're living when you're counting the number of living children, unless it says on the question that they've passed away. And I think I actually put an example question about that. If that's what I answered, then let me know. But if not, we can always type it in. All right, we're gonna go into the next slide. And then a stillbirth is a fetus born dead after 20 weeks completed weeks of gestation. We have some childbirth methods here, and we kind of have a cooler way to memorize this. So really just go ahead and really get that muscle memory going. If you're writing it in, that'll really help as well. We have our Bradley method. This is normal vaginal delivery. This is going to rely on partner coaching. Abdominal breathing promotes relaxation. And if you're looking for some way to memorize this, Bradley is abdominal. You got the AB, or if you want to think of it, Brad goes to the gym to get abs, abdominal. Brad is their partner, and then partner coaching. Really cool way. And next we have Lamaze. This is an education about fetal growth, training exercises that strengthen muscles during labor to decrease fear and help women cope with labor pain. Also, really summarized into patterned paced breathing. If you're looking for a way to memorize this to write on your PowerPoint slide, LAMA, pattern of alternating A's. So yeah, pattern paced breathing. And then Kitzinger, this is going to prepare a woman for a birth through a sensory memory of teaching relaxation, chest breathing with abdominal relaxation. If you're really looking for a way to memorize this, I believe K for Kitzinger and C for chest breathing kind of sounds similar. And then lastly, hypnobirthing, relaxation and relief of fear to experience birth in a calm, stress-free environment through deep and slow breathing with relaxation. And I really don't know a way to kind of make that, but I guess Gigi, I guess. Alrighty, so going into teaching, in our first trimester, we're doing really just a lot of physical and psychological changes. We're doing self-care. We're going to be choosing a provider and getting some prenatal experience done. We're also going to provide relief of common early pregnancy discomforts. So really, that could be nausea and vomiting, that could be having to go to the bathroom a lot, things like that. But it's also important to note that the first trimester is the most dangerous for the fetus. You'll learn about things like teratogen, the effects of what alcohol can do during this time, things like that. During our second trimester, being planning for breastfeeding, sexuality and pregnancy, what that is like, relief of pregnancy discomforts, again. Sexual needs may be a concern, so we must communicate with the patient and plan accordingly. Then going into the third trimester, a lot of teaching for this. We're going to be prepping for childbirth, developing a birth plan, getting some relaxation techniques kind of in there, a postpartum self-care, infant stimulation, infant care and safety, safety related to balance. And then of course, we're going to be teaching risks and symptoms of preterm labor. And we do have a lot of this. I kind of put on your slides that we're going to chat about this. So what I actually could do, since this is a lot, is I can even see if I can put it in the chat for you guys. I'm gonna share my screen to this. This is what we have right here. Can everyone see what I'm showing right now?
Yes.
Okay. You can always go back to the recording and really write all this down, but this is a lot right here. So a lot of teaching. Obviously, you don't want to be smoking because that can affect our placenta. The importance of being overweight or underweight during pregnancy, that can really affect our placenta as well. You know, some people in this day and age still don't get good prenatal care. So it's a lot of teaching about how important that could be. We're going to be teaching as well what kind of what things can occur if you're drinking alcohol or eating street drugs. And Professor Hur will kind of go over that. So for example, cocaine, I believe, is not good at all because that is a constriction effect, things like that. So that can, you know, relate to low oxygen levels in our fetus, things like that. Or if they're having health conditions already, such as high blood pressure, the effect that can do, you know, or if they're preeclamptic, if they have diabetes, blood clotting disorders or infections. You know, any of these risks can really just go into that. If they maybe have a history of twins, kind of communicating that and, you know, maybe getting a scan to make sure that isn't happening again, things like that. And then some of our symptoms of preterm labor could be if they're having a backache. This will be in the lower back, and she'll really go all this later in the semester as well. If they're, you know, getting some contractions and at the preterm level, if it's more than every 10 minutes, if they have any amniotic fluid leaking from their vagina, and this is whenever people say it's their water broke, that's kind of what that is. Maybe if they have any flu-like symptoms, if they feel any increased pressure, if they're having any increased vaginal discharge, or if they're just bleeding. And it's important to note that whenever patient's bleeding, that they know that they can go get that checked out. I mean, it's very important. Better safe than sorry. Alrighty, moving forward. We have our physiological changes in pregnancy. Right away, we're going to be having our uterine changes. It's going to increase in size and shape. It's going to move up into our abdomen. It's going to become more vascular. And they might have more urinary frequency. Why? In the first trimester, because, you know, that's just having to go pee. The uterus is growing, so that's kind of what's happening with that. In our second trimester, we probably wouldn't have as much urinary frequency because the uterus started elevated, and there won't be a lot of pressure on our bladder. In our third trimester, we're going to have urinary frequency again, because our mom this time is very pregnant, and there's going to be lots of pressure on the bladder, and that baby's going to be huge. And then we go into our three big things here: Hagar's, Chadwick's, and Goodell's. The way I memorized this was just kind of going by HCG. Always write it on top of each other, and that'll really help you. So Hagar is going to be the softening of our uterus. Chadwick's is going to be the bluish color of our cervix. And then the Goodell's is going to be the softening. I feel like that's kind of straightforward, but if you have any questions, I did put some practice questions in there to kind of test you if it really sticks with you till later. If you need another way to memorize it, maybe Goodell's. Having a soft cervix during this time is a good sign. There's also going to be a mucus plug within that area. Just basically that's making it safe. If there's going to be, if they're going to be having sex or something like that, it's safe for our baby to go and do that. So that's what that mucus plug does. And why is our uterine more vascular? This is because 1/6 of our blood volume is actually in the uterus during this time, and it's going to increase to about 40%. The mucus plug will going to put some notes more on that. The mucus plug is going to act as a seal to keep bacteria out. So that's kind of important as well. Whenever our labor does start, the cervix is going to dilate. The mucus plug is actually going to come out, and the body is going to be getting ready for labor. Alrighty. All right, here we have our reproductive changes. We already mentioned this, the cervix does create that mucus plug with estrogen. Our breasts are going to change. I know Professor Hurl kind of uses that term with estrogen, that the women they love how their body feels during their pregnancy. So estrogen, progesterone cause breasts to enlarge, colostrum secreted during our last semester. We have our antibodies, minerals, and proteins, and low levels of sugar and fat. So it's really important also for a mom to wear a well-fitting supportive bra. With cardiovascular changes, their pulse is going to increase. Their cardiac output is going to increase. Their blood pressure shouldn't rise, but it could happen. And when it comes to cardiovascular, this is really important, guys. If you have a mom laying on their back, the superior vena cava is going to be compressed. There's not going to be enough blood circulation going. Hypotension could occur. And if you're asked, how do you fix this? You're going to you need to kind of displace your body or put a blanket under your hip or something like that. So you really just want to move off those vessels. And if you're doing CPR, because that could happen, never know if when a patient comes on with an ambulance and they're doing CPR, sometimes they don't know that stuff. So it's really important for you to be teaching to displace our uterus first. And important note to hear, as pregnancy is advancing, the uterus is going to press on the abdominal vessels, vena cava and aorta. And it's important to teach a woman that a left wide lying position is going to relieve that supine hypotension and increase perfusion to our uterus, placenta, and fetus. That's actually what that thing is called. Whenever someone's laying on their back and it's getting compressed, it's supine hypotension. Physiologic anemia of pregnancy, due to our plasma increase, our HNH are actually going to go down. Hematocrit is going to drop 5 to 7%. In a normal value, it's going to be 38 to 47%. And then within a pregnant woman, it's going to go down to 30 to 46%. within musculoskeletal, pelvic joints are going to relax, causing a waddling gait, and relaxin is the hormone responsible for joint relaxing. Went over that last week. Within respiratory, these they're breathing for two, smiley face. There's going to have an increased tidal volume. They may have nasal congestion, stiffness, or nosebleeds due to vascular congestion of the nasal mucosa. Their capillaries are more fragile in the face, causing nosebleeds. If you really wonder, why do they have these nosebleeds? Just overall, if you're writing it down, high levels of estrogen and progesterone are going to increase the blood flow to our body's mucous membrane, including our nose. Alrighty. With renal, they're going to be having urinary frequency. Third trimester, baby's head is big and pushing on our mom's bladder. So if you haven't heard, or I mean, we've already mentioned it twice, but third trimester, urinary frequency, big baby, increased risk for UTI. This is really important because UTIs are a bit little dangerous with our preterm babies. So a lot of our times, these moms might not even be showing our signs and symptoms. Yeah, UTIs can cause preterm labor right there, and I didn't even see that. But undiagnosed UTIs can travel to our kidneys and cause pyelonephritis. And Lonasa may have even already kind of taught you guys about that. That's just an infection of our of our kidney. Okay. Integumentary, so we're talking about our skin. We're going to have our pregnancy mask, cloasma. Probably didn't pronounce that right. We're going to have the linea nigra, very kind of easy to spot. This is going to be that line on the stomach going all the way down. Of course, they're also going to get stretch marks. With our pregnancy mask, and it's important to kind of use sunscreen. These stretch marks should fade from red to silver, and the linea nigra will disappear eventually after the birth. Going into our endocrine, they're going to have a 3 to 5 pound weight gain in the first trimester. And then after that, they're going to have a 10 to 12 pound weight gain within the second and third, about 1 pound per week. Really going into hormones here with endocrine, HCG is our supported pregnancy hormone. This is the one that's causing our nausea and vomiting. HPL, that's the lactate ones. Insulin agonist, this is going to inhibit our insulin so mom can release more glucose for fetal growth. Estrogen, uterine development for fetal growth, stimulates breasts for lactation. Progesterone, maintaining the endometrium. This is going to lower our uterine contractility, causing relaxation of the smooth muscle. And then our prostaglandins, contributing to the onset of labor. So really just with HPL, with diabetes, it's important to think about the effects of this that can have on it. Alrighty. We have our psychological responses to pregnancy. Within our first trimester, we're going to have what's called ambivalence. And this at the time, even if they weren't, planning this pregnancy, they could have mixed emotions. They're going to be, confused. Like, am I going to be a good mom? How am I going to pay for this? If you're, looking way forward, 20 something years, how am I going to pay for this? Their college. But, Professor Hurl would say, that's 20 years from now. We'll think about that later. That's kind of what you told us in class. Within the second trimester, we're going to have quickening, and this is when the pregnancies is going to become real. This is also their golden time. Ambivalence that's going to kind of lean off a little bit, and the woman is going to accept a pregnancy during this time. During the third trimester, mom will often become introverted and self-absorbed, pop off, and then we're going to have mom beginning to ignore her partner, and this could have a strain on the relationship. Especially right before our labor is going to happen, they're going to go into a nesting phase. They're going to be wanting to clean everything, things like that. So very common. Maybe even with our ambivalence, they're going to have career concerns. How am I going to work? Things like that. But if you have a mom that wants to work during pregnancy, she very well can. Let them know that this is acceptable if there's no exposure to hazardous chemicals or toxins, and they can travel by car or plane. But you must teach them to stay well hydrated and to take frequent rest periods. I remember one time I was doing practice questions, and I heard a thing about women on a plane. What is she supposed to do? It's get near the aisle, get to where you can walk around every now and then. It's a long plane ride. So yeah, really good thing to know there. We do have right here this is a really good art piece. I gave this on the slides. Just follow that. I mean, if you're more of a visual learner, wanting to see some patterns, things like that, this can help a lot. All right, moving forward. This is very important, guys. Really just big hype on this. We have 3 things here, the 3 P's. We have presumptive, which is subjective. We have probable, which is objective. And we have positive, which is always diagnostic. This is going to be, so starting off with presumptive, we're going to have amenorrhea. So our girlie here hasn't, she's missed her period and she thinks she's pregnant. This is always subjective information here. So that's what that would be. This is signs of this presumptive would be what a woman says. And this could not even be associated with pregnancy. That's why this is the first P we're talking about. They could have nausea and vomiting. They could have fatigue. They could be peeing a lot, or their breasts can be changing, things like that. So really just fill that in. I know I'm making you guys write a lot, but I promise it's going to help you. Going in with our next thing, probable. This is objective. This is going to be noted by our examiner. May or may not be associated with pregnancy. Okay. We have the blottement. We have our HCG. So if they, that's our pregnancy test. They go in for the clinic, and they want to get a pregnancy test. That's kind of what that would be. Uterine enlargement. Braxton Hicks contractions. Their skin can be changing. Their abdomen can be increasing, or they're just developing stretch marks. And then we also have positive here. We have our diagnostic with fetal heart tones, fetal movement palpated by the examiner, and then of course an ultrasound. So really just if you look at it in a diagram this way, it's kind of very easy to kind of go on that. With probable, what blottement is it's a technique of an examiner's finger tapping against the uterus through the vagina to cause the fetus to bounce within the amniotic fluid and feeling it rebound quickly. And then, of course, below that is the Braxton Hicks contractions. These are irregular and usually painless contractions that come and go. Alrighty. All right, moving forward. We have our discomforts of pregnancy and interventions here. We have nausea and vomiting. Within nausea and vomiting, it's important for our mothers to maybe think about eating some crackers, carbonated beverages, maybe getting away from those nasty odors. Avoid drinking while eating, eating for small, frequent meals. And you can always reinforce this by saying, hey, this is not going to last forever. And this nausea vomiting will usually subside by week 13. Breast tenderness, it's important for our mothers to wear a well-supported fitted cotton bra. Within urinary frequency, we could tell our mothers, hey, you're gonna urinate more, decrease our evening fluid intake, so you don't have to go pee during the night, things like that. But of course, during the day, you gotta stay hydrated, so increase your fluids throughout the day. You're gonna be fatigued. Take those frequent naps. Go to bed as early as possible. Excess saliva. Maybe get some mints in there, some gums, hard candy. Within heartburn, eat small, frequent meals. Avoid our spicy and greasy foods. It's even important as well, some spicy foods, just stay away from those. Constipation, increase fluid intake, exercise, use stool softeners if need be. If they're having those hemorrhoids, avoid constipation, ice packs are needed. Sitz baths or warm soaks can be needed as well. A lot of times our mothers are going to be having a backache. So do some pelvic tilt exercises. Just exercise, get some stretches in there, things like that. We're going to have some leg cramps going on as well. So apply heat to those muscles. If our mothers develop varicose veins, elevate those legs, wear some supportive hose, don't cross your legs. Ankle edema, we could dorsiflex the feet. We're going to be avoiding standing for long periods of time, and elevate legs when sitting. If we're having faintness, have our mothers tell them, hey, whenever you're getting up, make sure you're going to be getting up very slowly and try not to stand for too long. Flatulence, it's important to tell our mothers, hey, avoid the broccoli, maybe chew your food thoroughly, and go to the bathroom regularly. Alrighty. This is reinforcement of last week's material, milestones. So at 4 weeks, and I guess as a headline, guys, for any of these milestones, if Harold is going over this and saying a different number, go off of hers. But I promise you as well, regarding whichever numbers you're using for these weeks, just getting a general idea will really help you. And, on her exams, it's never going to be like, 4 weeks or 5 weeks, it's going to be very obvious which one we're talking about. So just kind of that. 8 weeks, so all of our body organs will be formed. 10 to 12 weeks, our fetal heart tones can be heard by a Doppler device. 16 weeks, our baby sex can be seen. Looking at 20 weeks, we do have a heartbeat can be heard with a fetoscope. And this is when our quickening is occurring. Motherings are feeling the movement. At 24 weeks is viability. We went on this last week. Our respirations are beginning. We have 28 weeks. Our baby can breathe at this time, although surfactant is needed. 36 weeks, our lungs mature, and surfactant is ready to go. So if you have a baby coming in at, 32 weeks, we could have, it's important to know those interventions to increase that surfactant production before birth has occurred. GTPAL. This is really important, and I have given you guys practice questions on this. I typed them up 2 days ago. Gravity is number of pregnancies. Term is number of term infants born after 37 weeks completed weeks. Okay. Sorry, my phone's vibrating. Put on airplane mode. So just term, really think of that. Preterm, number of premature infants born between 20 and 37 weeks. We also have abortions here, number of pregnancies that end in a spontaneous or therapeutic abortion prior to 20 weeks. So already think of it as your weeks. Abortions less than 20 weeks, preterm 20 to 37 weeks, term 37 plus weeks. And then of course, living children, very reasonable. And then I put on your notes, I think we have gravida and para. We have gravida is the number of pregnancies, para is the births more than 20 weeks. Okay. Let's do a practice question, and then we're going to take a little bit of a break after this. Okay. Maybe we're going to pull the chat up. We have a girlie come in, 6 weeks pregnant. She has the following history. She has a healthy 2-year-old daughter. She had a miscarriage at 10 weeks. She had an elective abortion at 6 weeks. What would be her GTPAL? G3. Guys, actually four. She's pregnant already. She's had a daughter. She had a miscarriage and she had an abortion. So that's actually would be 4. T What would our T be, guys? We have, it would be 1. Our P, preterm, what would that be? It would be 0. And then A is 2. Yes. And the reason being, guys, is we have an elective abortion, but also a spontaneous abortion. Okay. And then L, what would that be? Yes, y'all are so good. And what would our G and P be? Gravida, remember, is number of pregnancies, and para is after 20 weeks. So gravida would be 4. Same thing, yeah, same G. And then the para would be, yes, good job. And you can always private message me if you want. You know, if you guys just want to full send it, but don't want to, if you get it wrong, you know, you don't want to have it on there. Alrighty, friends. So let's go and take a little bit of break. Does maybe a 5-minute break sound good? Alrighty. So I'll see you guys at 1:45. I'm gonna go and pause the recording. All right, our next thing is going to be going into our estimated date of confinement. This can also be our due date. I know a lot of times your professor, Professor Hurl, actually is going to come and bring those little wheel charts to class. Really cool, actually. So you can actually go ahead and, you know, figure out using Nagel's rule, this is going to be our first day of our last menstrual period. We're going to subtract 3 months and add 7 days. That'll always be those numbers there, so please write that down. We could also have the McDonald's method. This is going to be measuring our fundal height. This can be affected, though, by our maternal height, if they're having irregular growth, if there's maybe twins in there, or if there's abnormal amounts of amniotic fluid. And on the right would be kind of what the McDonald's method is. That's kind of just using it's really when it's like in the 20s that's really helpful. You know, it's like 22 weeks, if it's 22 centimeters, things like that. So keep going. And it's important to note that the McDonald's rule is not reliable as Nagel's rule. So this is important if a mom comes into, you know, the ER and she's like, I'm gonna have a baby, but she doesn't remember when her last menstrual period was. That's what they'll do. Okay. So we're gonna go ahead and another really quick practice here. Remember those numbers I told you were, make sure I have the chat right here. You're going to add 7 days, subtract 3 months. So what would this be? I'm just going to go and walk you guys through it. We're always going to use the first day of our last menstrual period, and we're going to add 7. So it's going to be 24. But then let's subtract 3 months. Okay. I believe that's July, I think. But so yeah, that'll be the expected due date for our baby. All right, moving forward. We have prenatal visits. This is very important, guys. Every 4 weeks for the first 28 weeks, every 2 weeks until 36 weeks. So when I thought of it like at first it's 4, after 28 weeks, it splits in half to 2 weeks. After 36 weeks, splits in half to every week until birth. Obviously, if there is any history of diabetes, hypertension, preterm labor, then we will be doing more frequent visits, okay? We're going to do UA. We're going to listen to fetal heart tones. We're going to measure our fundus. We're going to do a vaginal exam. We're going to make sure everything's going on okay. We're going to do measurements. And it's really important for you guys to have the, for their prenatal visits, to have the same person doing the exam, so it's very, I guess, accurate comparing the week before, things like that. And we should always identify and treat our problems early, okay? Next is prenatal labs. We're going to know the purpose. We want to know abnormal versus normal. And then we're going to know when the test is done and how. All right, moving forward. We have our H&H here. It's important to monitor our hematocrit for eclampsia, also called hypertension. With hemoglobin, it's important to know that we need to know if later down the line, once they're having labor, depending on what type of delivery we have, we should have estimated blood loss. I know Professor Harold would also, it's actually called, now they're doing calculated blood loss because, and once you go to clinical, you'll see this, but when someone's having a vaginal delivery, they're actually measuring all the blood that's coming out. So that's pretty cool. And during a C-section, we're going to be having estimated amounts of around 1,000 milliliters of blood. During a vaginal delivery, does anyone know what that would be? It would be 500 milliliters. So always remember, C-section's a actual, it's a very important surgery. So obviously you're gonna have a lot more blood come out there. We're gonna have a 25% increase in erythrocytes and 50% in our plasma volume. And just kind of as a definition here for you guys, eclampsia is a life-threatening complication of pregnancy. This is going to cause a pregnant woman, usually previously diagnosed with preeclampsia, high blood pressure, to develop seizures or coma. And this is really important. Personally, I think my mother was actually preeclamptic, so I was born early. So yeah, pretty cool. GTT, the glucose tolerance test. We're going to be screening here for gestational diabetes. It's really cool kind of how history goes with this test. Back in the day, they would, send them across the street, say, hey, order you some pancakes and come back and let's test your levels. Now it's a lot more different. We're going to give them an oral 50 grams oral glucose, and then we're going to assess them after an hour. If it is more than 140, it's abnormal. Then further testing will be needed, okay? And then regarding insulin, therapy is going to remain the same. During our second and third trimesters, insulin needs may need to be increased. All right, CBC platelets are going to be huge. An epidural will be withheld if platelets are less than 100. Remember that. Okay, hepatitis B virus. This is the most common infection in fetus, transmitted by blood, bodily fluids, transmitted to the fetus through the placenta, and can be transmitted during delivery. Hepatitis B surface antigen. If it's born positive, should be treated within 12 hours of birth. It's also important to note that the hepatitis B vaccine is not contraindicated during pregnancy. Herpes. This is really important. If there's actual lesions present, a C-section will be performed, but if there's no lesions, then a vaginal birth is okay. Cytomegalovirus, I totally pronounced that wrong. Teach mom to stay away from people with CMV. This can be transmitted through urine, semen, cervical vagina secretions, feces, breast milk. There are no licensed treatments for pregnant women who become infected with CMV during pregnancy. Next is going to be our torsion infections. This is really important, toxoplasmosis. This can be transmitted by handling uncooked meat or handling cat litter. So, if our mother has a kitty, maybe have her partner do that throughout her entire pregnancy. Say, hey, we're not going to be taking turns, type of stuff. So yeah. Next is RPR, VDRL. This is syphilis, essentially. Syphilis, a fetus can end up aborted, or more commonly, intrauterine death can occur. Early neonatal death. can occur as well, and survivors may develop features of congenital syphilis, such as bone abnormalities, hepatitis, anemia, and active neurosyphilis. Alrighty, that is RPR. Just remember that's test screening for syphilis there. I don't think she would test you on that paragraph underneath it, but yeah. Quad screen, optional screens for patients 14 through 18 weeks. Alpha fetal protein, elevated levels may indicate a neural tube or body wall defect or multiple gestation. Decreased levels indicate risk of Down syndrome, sorry, number 21. That right there, AFP is really important. HPV, HIV, this is a test for HIV screening requires. This does require informed consent though, so that's what I kind of highlighted it. When it comes to your STIs, gonorrhea, chlamydia, this could lead to miscarriage, or this could infect our baby during or before delivery. Next is going to be group beta strep, GBS. You'll hear this when you're in clinical. They'll say GBS negative or GBS positive, because GBS positive actually it is. I don't want to say it's common, but it just kind of happens sometimes. This is going to be caused by normal vaginal flora. This could transmit from birth canal of mother. So oftentimes they'll actually test this before, in our prenatal care before delivery. This is going to be a cultural, anorectal, and vaginal areas, not our cervix. If mom is positive, IV antibiotics are going to be given to reduce the transmission. And then once labor has occurred, or beginning, every 4 hours they're in active labor until baby is delivered. For our mom, this could cause some bladder infections, uterine infections. For a baby, this could cause meningitis, sepsis, high alert, pneumonia, and their baby could also result in death. Urine toxicology, urine cultural, UA. A spilling of glucose is okay. A glucose reabsorption impaired in pregnancy. Proteins in the urine, a trace to 1+ is okay. Increased proteins may indicate preeclampsia. If there's any white blood cells in the urine, this is bad. If UTI goes untreated, because a lot of times they won't know this is going on, kidney infection could occur, leading to early labor and low birth weight. If there's any ketones in the urine, indicating diabetes, and then preeclampsia is also called hypertension as well. Cell-free DNA, test maternal serum or for fetal DNA. This is a pretty high detection rate for trisomy 13, 18, and 21. If these results are abnormal, they'll do an invasive test will be needed, such as a CVS, chronic villus sampling, or an amniocentesis. And this stuff, these screenings and stuff like that are very important. I'm not sure if they're on your first exam. This stuff can definitely come up again, especially in HESI, stuff like that, okay? Underneath that, CVS, chronic villus sampling, obtains a small sample for chronic villi from the edge of the developing placenta. This cannot detect neural tube defects. This is an earlier diagnosis than in the amniocentesis. And I believe, guys, we're going to be going over these tests again later in the semester, and that's where we'll break it down a little more. This is actually going to be on your exam 2 pre-worksheet. So, if you could learn this stuff now, that'll help a lot, but we're going to go over it more later, okay? We have an amniocentesis. This is a needle going through the abdominal wall, taking that AF and amniotic fluid, which is going to contain fetal cells. This test is done at 15 to 20 weeks. And again, this is going to be testing for genetic disorders. We're looking at the LS ratio and PE. LS is going to be assessing for our fetal lung maturity. If it's 2 to 1 or greater, this indicates lung maturity. But yeah. NST, non-stress test. This is a non-stress test. So we're just going to put the fetal heart monitor on. And this is going to be done at 23 to 24 weeks. We're looking for 2 accelerations of 15 beats per minute lasting 15 seconds, over 20 minutes, or 10 beats per minute lasting 10 seconds. Where then we're going to have a stress test, a contraction stress test. We're going to be looking for our ability of our baby to withstand stress of our uterine contractions. So this is really testing our body to see how it's going to react to pregnancy. You know, we're going to look at our fetal heart monitor to see how, look at their heart rate during the stress, okay? Then we're going to look at the respiratory function of our placenta. We're going to have 3 contractions of good quality in 10 minutes, at least 40 to 60 seconds long. We're going to look if the fetus is at risk for low oxygen during contractions, because you'll learn about this, and you know, one day when we can get out I can borrow from Harold the placenta, things like that. When a contraction is occurring, the oxygen is cut off. So we're looking to see how that goes. Negative, 3 contractions of good quality in 10 minutes, at least 40 to 60 seconds long, no late decels. A positive is a repetitive late decel with 50% of the contractions. So with this test, I believe the negative is a good thing, and the positive is not good. So just kind of write that down. RH, sensitization, and RH factor. This is very important, guys. You might have learned this in A&P. You should have. I mean, Professor Metcalf goes over this really well. If you have a mother who is RH negative and a father who is RH positive, leading to an RH positive fetus, whenever our RH blood is from the babies coming into contact with our RH negative blood, this usually occurs when our placenta separates from birth, okay? It's important to know that the first offspring is not affected by these antibodies. So that baby that's coming out, the blood is merging, that's going to be okay. But in our second pregnancy, this could, mom has made antibodies. And if that baby is, a positive and our mom's negative, but she has made those antibodies, these antibodies are waiting for that RH positive blood to come around so they can attack it. Hemolysis occurs, mother's antibodies enter the baby through the placenta and cause that right there. I don't want to pronounce that, but I mess it up myself. So really, as a summary of this slide here, an RH positive mom and RH negative fetus is no problem. I'm gonna write that down. RH negative dad and then RH negative mom is gonna make an RH negative baby, so no problem. And if you guys have no idea what this is, the RH is whenever we're talking like, hey, I'm O positive, you're O negative, stuff like that, okay? We do have, and this stuff's really important because if you have complete red blood cell destruction, this could result in jaundice or maybe being kernicterus. And kernicterus is neurological damage of the actual severe jaundice, okay? All right, moving forward to the next slide. Then we're talking about rogam here. Rogam is not given to mothers who are already sensitized and have antibodies. So if a mother is sensitized, that means that she has made antibodies already. Therefore, the rogam will do nothing. Okay. Very important. I pretty much promise you will have questions or question rather between this stuff and this stuff. So very important. Please get to know this. We're gonna have 2 tests done here, and this is really cool because when you're in the nursery with the babies, they'll hear about stuff like this. You have a direct Coombs test. This is done on the baby, and you have an indirect Coombs test. This is done on our mom. So if you want to think about it, direct Coombs test directly to the baby, indirect on our mom, indirectly affecting our baby, something like that. Rogam is what we'll be giving at 28 weeks and 72 hours postpartum. If there's anything traumatic, let's say pregnant mom gets into a car accident, a lot of times we will give rogam as well. and we have to wait 7 months before getting pregnant again. Alrighty, rubella. We have our IgG antibodies are measured. This titer is going to be 1 to 10 or greater is going to indicate an immunity. We have some teaching with this. We do not. Why would we not want to give this while pregnant? Just you can't. It's alive, so you can't really do that. Okay. Teaching: do not get pregnant for 1 to 3 months after you are vaccinated. Okay. And rubella patients who don't have immunity to rubella should receive rubella vaccination during postpartum period to protect future pregnancies while not affecting current pregnancy. Why? You want to build that immunity. Maybe even if mother's breastfeeding, that'll kind of go through there. Give you some antibodies. It is administered postpartum before discharge, sub-Q if their titer is less than 1 to 8. And yeah. We're going to take a break, but this is when I was going to have one scheduled for us, but let's keep moving. Alrighty, guys. That was it for our slides. Now let's do some questions here. And I spent a lot of time doing this. So if whenever it comes to you guys doing your exam reviews, I appreciate if you go back to these videos and kind of watch these questions. Even like pause it, think about it before we go over the answer. Okay, so let's go. During a vaginal exam, our nurse is noting the lower uterine segment is softened. What would this be documented as? Yes, this would be B. Actually, I'm sorry, hold up. Let me check again. Let me check. I think it's A. Okay. A. Then the reason you might have thought B because you thought softening. So I'm gonna type in the chat. We have H, C, G. Yes. Okay. Here I put in the rationale. Hagar sign reverse to softening of the uterine segment. Blue is going to be Chadwick's. Goodell's is going to be softening of the cervix. So if you think about it, HCG, H is always above. If you write it on top of each other, HCG like a hormone here. H is going to be the uterus. It's all the way up there. The cervix is going to be down here. That's going to be G. Okay. And good job, Kyra. Yes. That's the way I thought of it. Just think of it on you're placing these letters on our human body. HCG. Okay, there we go. And if you really wanted to as well, think of it. Chadwick is a color. Blue is a color, so C and C kind of go together. I don't know. This is why I don't know. I just made random things up to memorize it. That's how we went through the class. Okay, next question here. Patient is in her 7th month. She reports she's feeling dizzy. Oh, I'm gonna pass out when I lie on my back. What would this be due to? We went over this, so you guys should be able to answer it. Pop off. B. Let's go. Yes. Very good. Pressure on the gravity uterus of the vena cava. The client is describing supine hypotension. That's what this is called, guys. This occurs when our uterus is falling back against the superior vena cava. And I wish I had my camera on because I'm like doing all of these motions with my hands, but my camera's not working right now. Don't know why. The vena cava is compressed, reducing that venous return. No oxygen is getting out there. Our blood pressure is decreasing, and that's kind of what's happening. If I want to put in there as well, pressure on our diaphragm would actually lead to dyspnea, which is low oxygen. Okay. Next question here. A woman suspecting she is pregnant asks the nurse about which signs would confirm her pregnancy. Which sign would confirm? Okay. And if someone could type in, ooh, so you already got it. Yeah. So I'm telling you, like, this is good stuff. I'm very happy for y'all. Okay. Confirming pregnancy, palpable fetal movement. I went ahead and put it on here. This is going to be C. Only positive signs of pregnancy can confirm pregnancy. the positive sign of pregnancy confirmed is that a fetus is growing in the uterus. Visualizing the fetus by ultrasound, also palpating and hearing a fetal heartbeat are signs that make the pregnancy certain. Okay. Very good. Very good. The client has completed an at-home pregnancy test with positive results. Which client statement indicates that the client understands the meaning of these test results? So proud of y'all. Y'all are popping off. Let's go. Yeah, reveal the answer. I understand that this means I might be pregnant. Yes. Yeah, very important here. Let's keep moving. And it's important to know that, you know, someone could test positive on a pregnancy test without even actually being pregnant. So that's why we're going to have this answer here. Okay. All right, let's do an example. A client comes to the clinic and she reports that July 10th was her first day of her last menstrual period. Using this Nagel's rule, what would the estimated date of birth be? So it's important to remember. Yes, you're right. Give it some more time for some other people before we go with the answer. We're going to have 3 and 7. That's kind of our magic numbers here. But it's kind of important to know what you're doing with that. We're going to be, I'll walk you through it. We're going to be adding 7 to the day. We're also going to be subtracting 3 months on our months. If that means you got to write it out, you know, July is, you know, this number on the month, things like that. That's what you could do. I know, like, if it's a month that you're not born in, you know, it kind of help. I don't know. So yeah, I know this is really cool. It's actually going to be April 17th. This is because, yeah, let's go. Yeah. No. Okay. Subtract 3 months and then add 7 days. And this is really cool because you guys could really, like, yeah, add 7 days. Subtract 3 months, add 7 days. This is really cool because I know I wasn't born on the day that I was supposed to on my EDC, but, you know, I remember when we were all in OB, we all kind of estimated when our mother's last menstrual period was. So it's really cool. I don't know if you, like, think of it a weird way, but yeah. Keep moving. This is going to be some of you guys' least favorite question maybe today, because this is very tough. And some people just really struggle with this, but we're going to work on this. We're going to love these questions. And when you see this on a test, you're going to smile because you have gotten some good practice in. Okay, following confirmation of pregnancy, the client has come to the clinic for our first prenatal visit. And remember, with this, our G is already going up 1 number, okay? She reports having a 5-year-old child who was born at 40 weeks. She has a 3-year-old triplet who were born, 3-year-old triplets who were born at 34 weeks, and a first trimester abortion when she was in college. On her medical record, what would this kind of enter as, okay? You are correct. That's good. Yes. Let's kind of, sorry for the lawn mowing, guys. My mic might be picking it up. She kind of fancy. Yeah, so I probably should have put in more gravida options because sometimes people struggle with that. And I want to really reinforce that we need to get some practice in. So if we see this stuff, we're popping off. So gravida is going to be 4. We have our first prenatal visit. So that's 1. She has a 5-year-old at home. That's 2. Triplets. When it's triplets, guys, that's going to be, you're always counting the pregnancies, not the actual number of children. So, you know, I'm twin, you know, we would be only 1 on this stuff. Okay. But obviously the living would be a little different. Okay. Yeah. So this is gonna be 4. Yeah. Let's go into the answer. This is A, gravida 4, para 1, term 1, because it was born at 40 weeks. We have an abortion here because we do have our first trimester abortion while she was in college. And then, of course, the number of living. And I'll kind of put this back in the chat. I'll type it in right now. anyone wants to put this in their notes on this slide, grab. Okay, I'm gonna mute myself so I can type this real fast. Okay. Okay, I typed it in the chat. Kind of had a little typo there, but we tried our best. Alrighty. Moving forward. We have a pregnant client coming to the clinic. Had a miscarriage at 10 weeks. She has a 3-year-old at home. The child at home was born at term. She delivered a set of twins at 28 weeks. Lost that actually died within 24 hours. How would this document in the prenatal record? So with this is gravida and para. Okay. Kind of help you guys out if you're trying to answer this right now. Gravida is our number of pregnancies. And then our para is going to be the number of births after that 20-week mark. So she has a 3-year-old at home that was born at term. So that's one of our P's. She had a 28-week gestation set of twins that died within 24 hours. So this, guys, would actually be C. Okay. And I typed this out already to kind of explain it. The client had a pregnant total of 4 times for gravida 4. Para is the number of pregnancies that have reached viability past 20 weeks. So in this case, we have the 3-year-old set of twins, the 3-year-old and the set of twins that reach that 20 weeks. Okay. I think maybe you guys, I think they put 3 for the para because the twins thing. Okay. So that's what that would be. Twins, you would only count as 2 if it's going to be the living. Okay. So if it would have had, what are the living, you would have put that. Okay. But actually this is not a good question, but the twins did die at 24 hours. Okay. So that's what that would be. Moving forward. We have a prenatal education, including danger signs report, which of the following are reported but indicate that our client needs some understanding. I'm sorry, I totally read that wrong. When indicate that the client understood the teaching. So yes, you've already gotten it right. Yes, pop off. Okay, let's keep moving then. Dizziness and blurred vision, that could be a symptom of preeclampsia, which is, high blood pressure, things like that. And the rest are not danger signs. Okay. Our mothers could be constipated. They could have the ankle edema. We talked about all of this. So very proud of you guys for doing that. Our client is screened for gestational diabetes with an oral glucose test using that 50 grams load. The nurse explains that this schedule should be done at which point in the pregnancy? Yes, you got that right. I'm so proud. Let's go. Let's talk about this now. 24 weeks, okay? And if that wasn't on the slide that we went over for this, I apologize. But okay. Moving forward. The client is considering having an AFP screening. She asks the nurse how a test on her blood can indicate a fetal birth defect. Which response by the nurse is the best? Yeah, these are those type of questions that you just, I'm happy that we can give these to you. I typed this one up the other day. Alrighty, friends. The answer for this, and let's go over the rationale. So maybe you can write this down on this question. Oh, I don't think that you'll have this one printed out because I kind of typed it up afterwards, but this is going to be C. When a baby has a neural tube defect, some of the AFP leaks out and is absorbed into your blood, which causes the levels to rise. The test detects that rise. I want to make sure that I put the right answer for this. So when I post the recording, guys, if there's any comments on that YouTube video, that'll be my adjustments, but I think this is correct. 100.6 degrees. All right, maybe this could be a typo, but I'm sorry, guys. I don't think I have. Let's make sure we have this here. Let me make sure this is correct. Let's go back to the neural tube. One of them, when it's increased, is neural tube defect, and then decrease. Okay, let's move forward. I'll get back to you guys. I'll get back to you guys. During our first prenatal visit, the client indicates having blood, having had rubella or the rubella vaccine. She hasn't had either. Which would be the appropriate action by the nurse based on this information? And with rubella, guys, we're not going to be giving this in during labor because this is a live vaccine, remember? So yes, this would be B. Taking a blood sample to assess the rubella titer. For rubella, patients who are not immune should receive the vaccination during postpartum, so after delivery has occurred, because we want to protect future pregnancies while not affecting our current pregnancy, okay? So if you just want to write down rubella vaccine postpartum if not had. The results have been returned from a completed blood cell count for a pregnant client who came to the clinical for her initial prenatal visit, which result will indicate a possible problem with oxygen carrying capacity. This one really goes back to just, this stuff we talk about even in med surge. Yes, guys. This will be B. Red blood cells, you carry our oxygen, yeah. The prenatal nurse considers that which of the following will be the best indicator for normal fetal growth. Can I give you guys a second on this one? With this one, friends, we're talking about fetal growth. So this would be more along the lines of looking at our fundal height. I think President Harold will kind of walk you through this. When it comes to our fundal height, it's really in those 20s when it's kind of it's very accurate for the fundal height kind of equaling the weeks gestation, and it could be +2 -2. So this one would actually be B. Okay. Next question. The client has come to the clinic because she thinks that she's pregnant. Which of the following would be the most definitive way to confirm this diagnosis? Yes, very good. Someone already submitted that. Yes. Y'all are killing this stuff. But let's
kind of think about this too. A is not going to be correct because let's show the answer so we're not getting some mixed up. This is D, yes, pop off. A is not, that is, she's missing her period. That's subjective. Positive Hagar sign, that would be objective. That would be in our, that's not definitive though, okay? Pigmentation changes of the breast, that is not definitive. That is also, yeah, okay. Within our next choice, palpation of the fetal movements, that last rationale that we had on there was very good for the definitive ways of diagnosis. So, because nausea and vomiting are just a big complaint of a pregnant woman, the nurse provides guidance to a 6-week gestation client by telling her to do which of the following. Yes. 2 correct answers already submitted. This would be avoid eating greasy foods. And we actually have a little rationale here. Of greasy foods should be avoided. Saltine crackers should be eaten before rising. Drinking orange juice has not been recommended, although considering ginger can help to alleviate the nausea and vomiting of pregnancy. Neither cinnamon nor nutmeg has been shown to alleviate these symptoms. It was recommended that these mothers eat small, frequent meals throughout the day. When assessing the psychological adjustment of an 8-week gravida, which of the following would the nurse explain to see signs of? Yes, so good. No confident, let's go. Yes, ambivalence. It is common for our mothers to be ambivalent about their pregnancy during the first trimester. A mother is experiencing nausea and vomiting every afternoon. The ingestion of which of the following spices has been shown to be a safe complementary therapy for this complaint? Yes, so BA. Ginger has been shown to be a safe antiemetic agent for a pregnant woman. That would be the rationale for this one, okay? And antenatal client is informing the nurse of prenatal signs and symptoms. Which of the following findings will the nurse determine are presumptive signs of pregnancy? Select all that apply. I always think of it as presumptive. There's an S right there. So this is subjective information. So kind of going off here. This is select all that apply. I'll give you guys a second. I'm going to mute up. Alrighty. We've put 1, 2, 4 on here. I think on here, I think I have this incorrect on here. I'm more along the lines of you guys. Let's go and check that actually. So I'm going to go and unshare the PowerPoint. Actually, we can just go back really far. Over a lot of slides today. I totally missed it already. I don't have it here. All right, well, on the ones that were given to me, it says quickening is presumptive. So we'll have to, I'll reach out to Harold and write this down. Oh, I totally went. Alrighty. The rationale that I have here is that 1, 2, 3, 4 correct, but I'll reach out to Harold. Okay. Amenorrhea is a presumptive sign, having no more periods. Breast tenderness is presumptive. This is saying that quickening is also a presumptive sign of pregnancy, and frequent urination is also a presumptive sign of pregnancy. Uterine growth is a probable sign of pregnancy, so that would not be the answer. Okay. Now that I'm thinking about it, I think quickening might actually be included in there, because probable is going to be, quickening is the feeling of the mom feeling it herself. So yeah, but well, I'll definitely reach out to her. Okay. Don't want to be getting you guys all mixed up. A woman has just completed her first trimester. Which of the following fetal structures can the nurse tell the woman are well formed at this time? This one's really important here, because when we're thinking about that fetal milestone chart, this is a potential question, that could come out of this stuff, and really wouldn't think of it that way, but I'll give you guys some time to answer. The answer for this would actually be, I think it's 1, 2, 3, not 4, but 5, because alveoli is very detailed of our lungs, and with the end of the first trimester, that won't be completed yet. Okay, I'll go ahead and read this rationale. Although not clearly visible on the ultrasound, the genitalia is formed by the end of the first trimester. The heart is formed by the end of the first trimester. The fingers are formed by the end of the first trimester. The alveoli will not be formed until well into the second trimester. And the kidneys are formed by the end of the first trimester. And the reason it would be actually genitals as well is because, there's that time when we can actually already tell the sex of our fetus. So obviously, it's going to be visible and well on that stuff. Okay. And that was it for our PowerPoint. So I'm going to go and stop the recording.